In this lecture, I'll be covering IV fluids. Here are the learning objectives I'll be covering. So just to begin, here are a few of the indications for IV fluids. First, they're used as volume resuscitation in patients that are severely hypovolemic. They're also used as a vehicle for other drugs, such as piggybacking them on top of another IV antibiotic or something. They're also used as maintenance fluids. Typically, this is around 75 to 150 mLs per hour. And then they can also be used just to keep the vein open, to keep the IV flush so that it doesn't block off. Typically, this is done with anywhere from 40 to 60 mLs per hour. Just so that you know, 42 mLs per hour equals 1 liter of fluid the patient will get per day. So a lot of times I see physicians do this rate. Whenever you're giving IV fluids, it's always important to document the patient's vital signs. If the patient's hypotensive, they probably need more fluid. If they're hypertensive, you usually need to back off on the fluids. If they're tachypneic, do they have underlying volume overload, which would mean that you'd need to decrease the fluids. Also document edema status. There's usually no indication to give IV fluids if it's just leaking into the extravascular space, so you usually want to turn them off in edematous states. Also document lung sounds. If the patient has rales, it usually indicates edema, so you'd want to stop the fluids. Also document heart sounds. If you hear an S3 or S4, it usually indicates heart failure. If you hear a murmur, they could easily precipitate fluid overload, so you may need to stop them. Also document urine output. Are they urinating enough for whatever process you're treating? Remember, the heart failure diuresis and the normal urine output should be 1 ml per kilogram per hour. When you're giving IV fluids, you really need to assess the need for this daily and stop them or decrease them as soon as possible. Ask yourself, do they really need the IV fluids today? Can they be weaned or turned off? The patient's family can also help with this a lot while treating. Educate them on the signs and symptoms of volume overload so that they know and they'll alert someone if the patient's starting to show signs of this. So I know this may seem rudimentary, but it's really important to understand the basic chemistry concepts before you give IV fluids. First, a solute. This is a substance that is dissolved in a solvent. This can include plasma proteins, ions such as sodium or chloride, magnesium, bicarb, glucose. Any of those are considered solutes. Solutes are dissolved in a solvent, which is a liquid, usually water. And then a solution is a solute that is dissolved in a solvent. For instance, this is what IV fluids are. Example is 0.9% normal saline. Osmosis is the diffusion of water from high concentration of water to low concentration of water across a semi-permeable membrane. So, osmolarity is the solute concentration in a fluid by volume. Remember, volume is dependent on temperature, which can fluctuate in a patient, so we don't use this term when dealing with the human body. Osmolality is the solute concentration in a fluid by weight, and this doesn't change in a patient. Tonicity is another common term that needs to be understood. This describes the ability of solutes to move in water. It basically describes osmolality relative to the patient's plasma and determines the patient's cell's hydration. Tonicity is very important because it helps us decide what IV fluid to put the patient on. For instance, if a patient is hypertonic, which means they have a high solute load, this pulls water toward it, which shrinks the cells. Whereas if they're isotonic, the solute equals the solvent, then there's no water movement, so the cell stays the same. However, if a patient's hypotonic, which means low solute, water moves away from it and the cell swells. Another way, or what I think the easier way to think about this, is effective and ineffective osmoles. So effective osmoles basically cross the cell membrane and they cause a gradient. These include sodium and glucose. Ineffective osmoles don't cross the cell membrane, so you don't get a gradient. These include urea and alcohols. So you're probably asking, why is this so important? Well, it helps determine what fluids to give the patient. So a patient that is hypertonic needs hypotonic fluid, and a patient that is hypotonic needs hypertonic fluid. However, you always need to ask yourself what fluid is hypertonic, isotonic, and hypotonic to the patient's physiology. Please go back and re-listen to this slide a few times if this doesn't make sense to you, as it's very important. So the thing that you have to remember is that if a patient is hypertonic, isotonic fluid is technically hypotonic to the patient, and vice versa, which is why you use isotonic fluid so much. If the patient is hypotonic, remember isotonic fluid is still going to be hypertonic to the patient. So normal saline or lactated ringer is still going to be hypertonic to the patient. So if you gave the patient if you gave a hypotonic patient hypertonic fluid, such as 3% normal saline, you would dramatically increase the patient's tonicity, which could lead to significant consequences. So here's an example to prove my point. So let's say you have a 32-year-old male presents to the ED with altered mental status after working out. Exam reveals signs and symptoms of hypovolemia. Vital signs reveal a blood pressure of 108/64, heart rate's 110, respiratory rate 20, he's afebrile, and his weight is 65 kilograms. Labs reveal that his sodium is 120, glucose is 110, and BUN is 10. What is the osmolality? So if you calculate this out, 2 times the sodium would be around 240. And then if you took the glucose, that would be around 5. And then the BUN divided by 3 would be around 3. So then their osmolality would be around 248. But remember, this reflects effective plus ineffective osmoles. So then what would the tonicity be? Remember, tonicity is just the sodium and the glucose in that formula. So this would be around 240 plus 5-ish or so for the glucose divided by 20. So it would be around 245. So you can see it's really not that much change from the osmolality, and then you know that the patient is hypotonic. So what is possibly going on with this patient? More than likely, this patient has exercise-induced hyponatremia. You could tell that he was hypovolemic after working out. He's younger. His blood pressure's lower. His heart rate's high. He's got all the symptoms of exercise-induced hyponatremia. So what IV fluid could you give this patient? Well, a lot of times you might be thinking, well, I need to give him hypertonic fluid. However, this is going to raise his sodium very, very quickly. Remember, that's very dangerous. You want to go up on it slowly. So I would give this patient normal saline. He needs something isotonic. You could also do lactated ringer, which is isotonic. Typically, for these types of patients, I would give 2 liters as a bolus, followed by 100 mLs per hour as maintenance. Let's do another simple calculation. Let's say you have a 60-year-old male who presents to the ED and labs reveal these. What would be the calculated osmolality? Well, you'd take 120 times 2, which would equal 240, plus 100 divided by 20, plus 20 divided by 3, which would equal around 252. So this patient has low osmolality. The tonicity would just be the 240 plus the 5, so this patient would also be hypotonic at 245. Now back to IV fluids. There are 2 types, crystalloids and colloids. Crystalloids contain water plus electrolytes. They cross the cell membrane, and they expand the interstitial and the intravascular volume. They are typically grouped as isotonic, hypertonic, and hypotonic, and it's very important to understand which fluid is which. Colloids, however, contain large particles. They've really fallen out of favor. They're not used as much anymore, and they really don't cross the cell membrane. Now let's discuss crystalloids. This is a chart I would highly recommend putting in your peripheral brain or in your phone, something for your rotations to refer back to. It tells you what the ingredients are, the osmolarity, and the tonicity of most common IV fluids used. Talk about is 0.9% saline, also known as normal saline or NS on your rotation. It contains 154 milliequivalents of sodium and 154 milliequivalents of chloride. Now you may be asking yourself, but wait, a normal sodium is 135 to 145. How is 154 isotonic? The answer here is if you take 0.9 times 154, it actually equals 138, which is right in the middle of where a normal sodium level should be. The same thing goes with the osmolality. If you calculate that out with sodium and then you enter it into the patient, it will actually become isotonic. So it's basically salt water. It replaces both salt and water. So the uses for it, typically think of dehydration or hemorrhage, such as a patient with nausea, vomiting, or diarrhea, or who has a GI bleed perhaps. Also, it's used in shock, including hemorrhagic, cardiogenic, and hypovolemic. It's also used in mild hyponatremia. So remember, if you are hyponatremic, you are likely hypotonic. Therefore, normal saline will be hypertonic to the patient's plasma, so you will gently increase the sodium level. It's also used in metabolic acidosis, as most patients with metabolic acidosis are dehydrated. It's also used for diluting drugs or toxins. And the contraindications for it are hyperchloremia. So if you look at it, it contains a lot of chloride in it also. So if the patient's chloride is going up, you could see their anion gap change. So therefore, you would want to change the isotonic saline from this to, say, lactated ringer if you have a patient whose chloride's going up. The next isotonic fluid, lactated ringer, otherwise known as Hartmann solution. It's the closest fluid to normal plasma, and it contains lactate, which is converted to bicarbonate in the liver. So remember, lactate is the compensatory base for lactic acid. So lactate plus hydrogen equals lactic acid. It also contains a little bit of potassium and calcium. Its uses are very similar to normal saline, but it adds electrolytes. So typically surgeons love lactated ringer. It's typically used in surgical patients, burns, and trauma. It's also used in hyperchloremia, such as a patient that needs isotonic fluid, but you don't want to give as much chloride as is available in normal saline. Some common misconceptions with lactated ringer include hyperkalemia. It's sometimes believed that it can actually worsen your potassium. However, LR contains 4 milliequivalents of potassium, which is however, this is such a small amount compared to a patient's total pool of potassium that it usually trends the potassium more toward normal, even in end-stage renal patients. However, we still typically avoid this in renal disease. Another misconception is that it can cause lactic acidosis. Remember, LR contains sodium lactate, not lactic acid. Lactate is an energy source for the body, whereas lactic acid is a waste product. Some contraindications, though, include liver disease. So if the patient has liver disease, then they're not going to be able to break down the lactate into bicarbonate in the liver. Another is severe metabolic acidosis, which I'll actually talk about in a later lecture. And finally, it does need very close monitoring in renal disease as it does contain a little bit of potassium. Now we'll talk about hypotonic fluids. The first hypotonic fluid we'll talk about is D5 half normal saline, and typically with this we add 20 milliequivalents of potassium chloride to make the fluid. Now this fluid contains dextrose, also known as glucose, which creates an osmotic gradient when it is broken down. So it is hypertonic outside of the body, but becomes hypotonic after it enters the body. Common uses for it include treating dehydration in which carbohydrates are required, such as hypernatremia due to dehydration. It's also often used in pediatrics, and contraindications for it include hypervolemia, such as heart failure, hyponatremia or hypochloremia, clinically significant hyperglycemia, and it's also important to remember that this can increase intracranial pressure, which would cause cerebral edema. The next fluid we'll talk about is half normal saline, also known as 0.5% saline. So remember, this will drive fluid into the cell, so it's used to hydrate the cell, but it depletes the intravascular space. Its uses include when the cell is dehydrated, such as nausea, vomiting, and diarrhea, or when the patient is hypernatremic, or if the patient has DKA or HHS. Contraindications include if the IVC is depleted, such as hypovolemia and hypotension, trauma, burns, and it's contraindicated if as it can increase the intracranial pressure, which would cause cerebral edema. The next hypotonic fluid we'll discuss is D5W, also known as D5 in water. So this is used to replace free water when the patient is hypoglycemic and also has concerns as the patient is NPO. It's typically used in patients who are hypernatremic plus hypoglycemic or NPO. It can also be used in hyponatremia when it has been overcorrected. And it's also commonly used to make a bicarb drip. Typically in a bicarb drip, 1 amp of sodium bicarb equals 50 milliequivalents of sodium. So if you add 3 amps of bicarb to a D5W bolus, then you're getting an isotonic fluid, so you're getting a bicarb drip. If you were to only add 2 amps, then it would be hypotonic, which could be necessary also for the patient. It's typically used to treat non-anion gap metabolic acidosis, which I'll talk about in a future lecture. Now I'll talk about hypertonic fluids. Primary hypertonic fluid is 3% normal saline. This has a high osmolality which pulls water from the cell to the extracellular space. It is considered a volume expander. It is very, very dangerous drug, actually. It's typically only given in the ICU, and its uses include severe symptomatic hyponatremia. Contraindications is that it can cause severe volume overload and pulmonary edema, so it's usually only given as like very small boluses, usually like 250 to 500 mLs at most. Sometimes I've seen only 100 mLs given at a time, and then they repeat the sodium an hour later just to see what it's gone up to. Now I'll talk briefly about colloids. So colloids basically expand the intravascular volume via high oncotic pressure. Precautions with them include volume overload, allergic and anaphylactoid reactions. Colloids come in two basic types: albumin, which is very expensive, and HES, or Hespan, which is a little expensive. Albumin comes as 5 or 25%. It's really not used very much anymore, although it used to be used quite a bit in the past. And indications for it include either shock due to plasma loss, such as acute burns, or in severe hypoalbuminemia, such as liver failure plus anasarca. It's usually used in large volume ascites removal. Whereas Hespan, honestly, I've never even seen this drug used, so I really didn't know much about it when I formed this lecture, but it comes as 6% or 10%. And indications for it include rapid expansion of intravascular volume. So you may ask yourself, how much fluids do I actually give the patient? Well, you have to decide whether you're resuscitating the patient or you're just providing maintenance fluids. If you're resuscitating the patient, crystalloids are typically used over colloids. Like I said, colloids are rarely used anymore. The rule of thumb: usually surgeons prefer lactated ringer because for surgical patients or burn patients, they need those extra electrolytes, whereas general medicine patients require normal saline as their isotonic resuscitation fluid. Typically with this, you have to use your own clinical judgment at how much of a deficit you think. There are some calculations for how to calculate the deficit, but they're very complex and I won't go through that during this lecture. Typically, you give 1 to 2 liters as a bolus, though. For sepsis, you usually do 30 mLs per kilogram initially. However, you have to always look at the patient's renal function and heart to make sure that they can actually tolerate that much fluid. For maintenance fluids, there's 2 ways. You can look at their average I&Os and determine how much fluid to give them, or you can use the 4-2-1 rule, which I'll talk about in a couple slides. It's important when determining maintenance fluid for the average human being that the average input for a person is around 1600 mLs and the average output is around 1600 mLs. So if you divide 1600 mLs by 24 hours, this equals about 66 mLs per hour, which is why we typically begin isotonic saline for maintenance fluid at 60 to 75 mLs per hour. Another way to look at this is using the 4-2-1 rule. This is basically used for adults and peds and is calculated by 4 mLs per kilogram per hour for the first 10 kilograms, which equals 40 mLs per hour. Followed by that is the 2 rule, which is 2 mLs per kilogram per hour for the second 10 kilograms, which equals 20 mLs per hour, and then 1 mL for every kilogram per hour for subsequent kilograms. So since we're primarily treating adults here, you can actually break down this formula into their weight in kilograms plus 40. However, if you were doing pediatrics and the patient was under 40 kilograms, then you would actually calculate using the 4-2-1 rule. So as an example, for an adult weighing 75 kilograms, you could just take 75 plus 40. That would equal 115 mLs per hour. That would be their maintenance fluid. I know that may have been difficult for you guys, but please feel free to go back and listen to it again or ask questions on the Google Doc, and I'll try to get to them as soon as I can. Here are the sources for this lecture.